William has developed. They've won prizes, and they've made a tremendous difference in the public sector in terms of the Vula mobile app, in terms of connecting junior doctors and specialists. He can tell you more about that, but they played a particularly specific role in COVID. And we look forward to seeing what he has to say about that. We've had the privilege of being able to help Vula Mobile with some of their reporting and dashboarding and analysis in a very limited capacity, but nonetheless a privilege. So we look forward to hearing what he has to say about their intervention. And then Sheetal, it's very difficult to think about COVID and think about what good could have come of this crisis, this pandemic, and this absolute horror show that we've gone through globally over the last months. And what I can tell you is that for me personally, one of the amazing things that has come out of that is just meeting extraordinary people. And Sheetal is one of those people. She's a just extraordinarily gifted modeler, mathematician, etc. She's done amazing things in malaria, and she got pulled in early on into the National Modeling Consortium at the NICD. And I had the great privilege of being in some of those early conversations with the NICD and listening to the modeling, and lots of good arguments and debates and disagreements early on about how to tackle some of the things. And I learned an enormous amount through that process. And as I say, it's just been a great privilege and benefit to get to know someone like Sheetal over that process. So that's about all of the gushing I think is worthwhile to do on an early Monday morning. It's William up first, Griselda.
Yes.
Okay, William, over to you.
Thanks very much for the invitation, and thanks to Barry for all the support and insights given us over the last few years. So I'm going to share my screen. So with a bit of luck, you can see the road to my first job. Can you see that road?
Yes, yes.
Great. So yeah, I'm from the Eastern Cape. Rural health is my passion. So when we did our community service, we were determined to go back there. We worked at Madvileni Hospital, served a population of about 250,000 people. And we had 3 doctors and a team of very dedicated nurses. But we were junior doctors and we couldn't do everything ourselves. So this is a letter that I wrote myself in 2004. Sending the patient to Mthatha for an urgent eye condition. I didn't know what it was. So he said, please go to Mthatha. It's only 3 hours away and I hope that they can help you. And the next time I saw him was 7 years later. I went back to volunteer, and health records there are on paper, and they're literally kept like people's Bibles. They carry around with them for 7 years, literally longer than you probably have a cell phone. He had gone blind in that eye, and I realized then that we actually had the medication he needed the first time I'd seen him 7 years previously. So just a small piece of specialist advice would have actually saved that gentleman's eye. As you know, our patients travel huge distances to reach specialists, and sometimes just any old healthcare. However, it was only when I started specializing, this is me specializing at Tygerberg Hospital. You can see I'm teaching 2 students, I'm seeing a patient, and there's another patient waiting, and there's a phone in the corner just ringing off the hook with people like me in the past trying to get hold of a specialist. So we had to solve the problem on both sides. In the past, referrals were made on landlines, beepers, letters that I wrote. It's impossible to kind of analyze those patterns. You're probably aware that many people are using WhatsApp, which is not appropriate for medical communication, or not ideal. And that's why we built Vula Mobile, so that you can actually message people securely and you can actually keep your data for analysis. So our vision was to solve the problem that I faced on both ends, to give every health worker access to specialist advice. It's a simple app. You download it from the App Store. So if you're a health worker on this call, you can download and register. And it makes it much easier for you to get advice from specialists. We started off in ophthalmology. It's now available in 53 different specialties and disciplines. And I'll go through some of the specialties later. The secure chat is basically enables asynchronous communication. So rather than writing a letter and hoping for the best, or rather than having a phone ringing off the hook, asynchronous chat communication is actually the most practical in the public sector. Every specialty form on Ruler is different. So the one on the left there is the Burns calculator. The one in the middle is a vision test that's built into the ophthalmology form. A bit of history. Back in 2016, we were recognized by Amazon, that a City on the Cloud competition. In 2017, the World Bank recognized Ruler as a solution for rural healthcare. We got our first tender, government tender in the Western Cape in 2018. We won Best Health App or Best Health Solution. We beat Discovery into second place last year. And this year, as you probably guessed, we've all gone viral. So the impact of Ruler has been studied. There are a few studies available, and the average reduction in physical referrals is 31%. And the response times from the specialist is less than 15 minutes. And this is in the public sector. This is a huge improvement on the letters that I used to write, and fewer patients have to travel. Of interest, the highest reduction was in obstetrics and gynecology, and the reduction there was 52%, because basically the peripheral health workers were doing the right thing, but they just needed to be reassured rather than referring all the patients to the tertiary hospital. So let's talk about COVID. I know it's very topical at the moment. When the pandemic first started, we worked with BackaBuddy to raise funds to provide PPE for doctors and health workers in the public sector. So we raised money through BackaBuddy, and then Gift of the Givers would deliver them. And it was a real great honor to work with those two organizations. I then went up north. I went from Cape Town to Joburg to see if I could help with the NICD and the NHLS. And we started doing data collection for them. But actually it wasn't helpful, because what actually ended up happening was that we would be collecting data that they were already collecting, feeding it into their system, and we're messing up the actual accurate stats. So they politely asked us not to do data collection for them, but rather to help with their helpline. So their helpline was manned by 15 medical students, and it was answering calls by both the public and the health workers. And that meant it was impossible really for health workers to get the advice they needed. So we were part of a team that set up the Doctors on Call helpline. This is a helpline that any member of the public could call, mostly used by people without medical aid. We had 150 private GPs volunteering on this line, which was amazing to work with many of them. In terms of where the calls came from, a whole variety of places where it was advertised, like social media, and actually relieved, this is just one day's data, and it relieved a lot of the pressure on the NICD hotline as well. And we had different helplines at different times. So right at the beginning, none of us doctors knew what to do. And so we put some NICD experts onto the app, and people were allowed to ask questions. And so the health workers learned case by case during March, but once they'd learned enough, they stopped using that service. So there's been a whole bunch of different waves. We're talking about the second wave, but I'll show you how many waves there have actually been. So initially, when the Doctors on Call helpline started, the number of calls was going up in April, but then every time the president spoke, the calls would drop for a few days, and then they would peak again with new questions. So what we'd recommend is that the president speaks more often for our next pandemic. The next two peaks were related to COVID testing. So we linked up with Discam and other private pharmacies to offer free COVID testing to people without medical aid. What was interesting, these are just the number of calls. And in 75% of the cases, so 3/4 of the calls, they all wanted free testing, but the private GPs realized that they didn't need testing. All they needed was reassurance and information. So for example, if we had a public sector helpline for diabetes or hypertension or any other chronic condition, it's likely that we can actually decrease the number of physical visits to health centers. And I'm very proud to say that the Doctors on Call helpline, public-private combination of skills and resources, has been nominated for another prize. So if you look at the wave of admissions, so Ruler was used for the referrals to the Khayelitsha MSF COVID hospital, as well as the COVID ICU at Christia, as well as to the field hospital, the Hospital of Hope at the Cape Town Conference Centre. And the referrals there sort of peaked at the end of June, beginning of July, and there's been kind of a long tail that's still dribbling on, but the numbers have reduced significantly. Really want to mention the dedicated health workers that have been involved in the last 6 months. Many of them have passed away, many friends, and I'm sure you know people who are close to you. So to dedicate some time to them, because we also just recently released free COVID testing for health workers. So if you're a health worker of any sort, ambulance driver, pharmacist, doctor, nurse, you're able to get COVID testing via Vula. And again, this is a huge partnership. So I think like the Inside Actuaries theme is connecting the dots. And I think one of the most special things during COVID for us anyway has been the amount of networking and the amount of collaboration between different partners. So what's going to happen next in the public sector? Did lockdown break the system? So if we look at orthopedic referrals, this is across 5 provinces. Sort of pre-lockdown, we had our usual kind of rates. We definitely had an impact during lockdown. The number of trauma cases dropped significantly. However, with the new kind of back to normal approach, the numbers have gone up again. So lockdown had an effect on the amount of trauma. Summer is coming. So I know that winter was a bad thing recently on TV, but summer is a bad thing for us because in the Western Cape, there's a decrease in trauma cases being referred to the tertiary hospitals. And there's a corresponding increase in the Eastern Cape. So we do need to support the more rural provinces, perhaps with more human resources over the next few months. COVID isn't the only infectious disease at the moment. We've been living with TB for a long time, and the number of referrals to the TB hospitals have been really minimized during lockdown, and now they're suddenly rising rapidly again. These are the referrals to the Brooklyn Chest Hospital in Cape Town. There's also a backlog of elective surgery happening. So pre-lockdown, the number of elective cataract surgery bookings was already decreasing because people were aware that they weren't going to get appointments during the pandemic. Really dropped right down, people being booked 6 months in advance often, and it's still low. So we know there's a backlog of elective surgery cases that need to be triaged and helped. So the other thing that happened is a lot of children didn't get their vaccinations after the last, over the last 6 months. So we've just put the National Vaccine Helpline on Vula. So if your child has missed a vaccination, you can go to the nearest health worker. They can contact the National Vaccine Helpline on Vula and you'll get the help that you need. In terms of mental health, we looked at psychiatry referrals as well. So pre-lockdown, there was a certain level. This is from Critiskia Psychiatry. Dropped a little bit during the lockdown period. But it's rapidly increasing again now. And I think this might be due to more of the medications that weren't taken over the last 6 months, or just a return to kind of a busier section. I think that the lockdown had a lot of bad mental health effects on all of us. So one of the bonuses of using Vula for mental health is that the Mental Health Care Act forms need to be filled in correctly. And this is done and monitored via Vula so that we don't end up with any medical legal issues. So where's everyone going? Because no one's been attending health facilities for a long time. So we looked at the referrals to emergency medicine. So pre-lockdown, they were high, but this was normal. During lockdown, there was an initial decrease during the lockdown period, which kind of returned to normal. And the really kind of horrible thing is they're now being overloaded. So people, rather than going to their clinics or rather than going to their GP, they're overloading the emergency medicine services in the public sector. So this is a quote from one of the emergency medicine doctors in Kailicha. And just being able to get to the right doctor at the right time actually saves the public sector doctors time, anxiety, and frustration. So what we really need to do is improve triage. There's a great article in the Harvard Business Review. So how it's going to happen. So either the loudest voice wins. So the most dominant doctor or nurse is going to book the appointment earlier. Or it's going to be the richest win, someone who pays more to go into private and books the theatre first. Or it's going to be a first come, first serve, which some people see as fair enough. But actually what we really want is systemic triage systems. And that's one of the reasons that people are now using Vula for booking elective surgery. For example, for ophthalmology, they've now included questions like, do you drive? Do you need your vision to work? And several others, so that people can be triaged for the elective surgery more accurately than before. So there are some ways of efficiency in the public sector. The public sector has a huge drive towards efficiency, despite what some people might think, because we have to make the most of scarce resources. For example, these are referrals to Free Hospital in East London. you can see there's a wide variety of places where it comes from. However, most of the referrals actually come from Butterworth. So if we just send one doctor to Butterworth once a week to do the trauma cases, you'll save a lot of transport in the opposite direction. For those of you who don't know, Butterworth is about an hour and a half from East London. This is another case. Sister Elise Montonison is at Vredendal Hospital, which is north of Cape Town. And she learned case by case on Brula to the extent that we should stop making referrals. She accepts referrals from her area. And once a month, the surgeon does go to operate for her. So the number of referrals down to Tiger Hospital has decreased dramatically thanks to her initiative. I also believe that we're going to see waves of more efficient collaboration between public and private going forward. Just a couple of examples. On Sundays, the trauma cases are referred from Karl Bremer Hospital to Tygerberg. This is only about 5 kilometers away. However, they typically wait about 2 weeks for their surgery, whereas they're usually driving past 2 private sector hospitals, the Cape Eye Hospital and Melomed. They are empty theatres there on Sundays. So if we use public sector doctors in a private facility, we'd save 2 weeks of bedtime per patient. Another example recently is a child who had a head injury in Grabo. They sent a referral on Vula to the nearest public sector hospital that they thought had a CT scanner, which was on a Sunday. And the Mitchell's Plain doctor said, sorry, they don't have a radiologist on Sundays. Please send the patient through to Red Cross Hospital. The patient was admitted there, had a CT scan, and sent home the next day. It's a lot of transport, time, and money. Meanwhile, they drove past 2 private CT scanners in Somerset West. So I really believe that going forward, we can do a lot more with what we've got already. So I thought about just one extra thing in terms of the future. Obviously, coming from a more rural background, maybe I'm used to living with animals more than some. But basically, if you look at Helsinki and many of the European countries, they've actually trained dogs to test for COVID. So dogs have a really good sense of smell. So for example, we can taste a lump of sugar in a cup of coffee. They can taste a lump of sugar in the equivalent of 2 Olympic-sized swimming pools. So basically, we've got a lot of high-tech animals around us, and I think it's about time we use some of the simple solutions rather than relying completely on technology. So in terms of connecting the dots, I think the days of public-private partnerships are over. We need public-private, government, NGO, and academic partnerships. I'm very proud to say that we are supported by many companies, including Inside Actuaries for some of the analysis, and financially from a range of private sector companies, NGOs, and universities. So thanks very much, and looking forward to answering your questions.
Thanks, William. Super impressive as always. It's a stark reminder of just how strong and influence someone as driven as yourself can be, the right time, the right place, but also lots of motivation, lots of innovative ideas, and it's always inspiring to hear just how the size of the effect that you guys have had. Gazelle, are we doing questions at the end, or do you want to do them in between?
Yes, we're doing questions at the end, so maybe Sheetal can start sharing her screen so long. I also just wanted to comment on William's presentation. Quite interesting to see the increase in psychiatric referrals. You mentioned there might be an issue with medication there. I did also see some stories about the supply chain actually impacting psychiatric medication. So that does seem to be a bit of an issue there, but quite interesting to see, you know, similar trends in the public sector compared to what we see on medical schemes. So thank you. I'll hand over to Sheetal.
Thanks so much. Well, good morning, everyone, and thank you very much for having me on this forum this morning. So as Barry very kindly introduced me, I'm a disease modeler based at the University of Cape Town at the Modeling Simulation Hub Africa. And quite early on in the epidemic was called in to help with the modeling aspects of COVID-19. It was a period of great uncertainty, and disease modeling is one of those tools that can really be useful in times like this with managing diseases in general. where did we really, what part did we play in government? Barry mentioned the modeling consortium, the South African COVID-19 modeling consortium, and we were called to be part of this group. And it's a group of researchers from academic, non-profit, and governmental institutions and business across South Africa. And our task as a disease modelers was to develop epi and econ models in order to provide some insight as to where this epidemic might be heading and what the impact of it would be in South Africa. And this was around the time of early March when we were called to be a part of this group. So the work that my unit, Masha, did with the modeling consortium was in conjunction with two other disease modeling groups, Sasima at the University of Stellenbosch and Hero at the University of Witwatersrand. And the three modeling teams together joined in order to work with the NICD in order to provide projections for national government. But at the same time, we weren't really working alone. Along with others in the consortium, we were able to receive extensive input from experts like clinicians and virologists, those working in intensive care units, public health specialists, epidemiologists, economists, actuaries like Barry, and many others with such expertise in order to help us frame the modeling thinking, to define the key modeling assumptions, and to discuss parameter values and knowledge around COVID as it was evolving almost on a daily basis. So by now, sitting at on Sunday, 4th October, we're at the point where our epidemic has been declining quite nicely over the last month or two, and we're sitting at around close to 17,000 reported deaths, with just under 700,000 cases, positive cases identified, and what seems to be a steady set of new cases that are being detected on a daily basis. Now, as we reach this, as we're well into this decline of the South African epidemic, what it does is gives us time to reflect on the on our modeling so far throughout this epidemic, but also on the approaches that we've taken and what we could perhaps do better the next time round. So to start off, I think it's quite important to understand who disease modelers really are. Now, we've actually, as our profession as disease modelers, we've been around for over 100 years. But for many people in the public, not just in South Africa, but worldwide, we had only really heard about disease modelers during the COVID-19 epidemic. So our profession increased quite a lot in popularity, I'd say, fame and infamy during this epidemic. But who are we really? What is our skill set, and what does it take to be a disease modeler? Not just somebody who works in COVID, but somebody who works in diseases in general. So we have a certain set of skills as disease modelers, and we often come from various backgrounds. So primarily, the background that people come with is mathematics or biology, and the reason behind this is that disease modeling is a mathematical process, but it's not just a set of equations. It's a set of equations that represent the underlying disease process or disease manifestation. And so that's why an understanding of biology, of virology, on how a disease works is critically important, so that one actually knows how to translate these medical processes into mathematical equations. At the same time, 100 years ago, these equations were solved by hand, when these equations were tractable and could be solved by hand, and iterative procedures were done on large reams of paper. But these days, of course, with increases in computing power, we're able to achieve a lot more with our disease models. And so one needs to have a good understanding of computer science so that one can actually translate these equations into computer language in order to process them. Now, of course, one doesn't have to be a master in every single trade possible, but if one doesn't quite know, if you're a mathematician who understands biology and doesn't have a good computer science background, then you will fall short when it comes to truly understanding the execution of your code and what is actually happening with the different solution methods and with the time it takes to actually process code. At the same time, our models are only as good as the data that are informing them. And so background in statistics is certainly useful in order to understand the data, where it comes from, how good it might be, as well as how to process it when it comes to model fitting. And this increases the robustness of the models that you create. And a good understanding of economics is also vitally necessary, because there is almost no point in designing a disease model being able to project what interventions are useful to control or to combat this disease, but not be able to assign a cost of doing so. Unfortunately, resources are limited, and so we have to be able to choose between different interventions and weigh not just the health benefits, but also the opportunity costs and the money that is being dedicated towards these interventions. But underlying all of this, with all of these skills, maths, biology, stats, computer science, economics, what ties it all together when we are working with diseases in the public sector is an understanding of the health system. There is almost no point building a model for TB if one doesn't understand how patients access TB services, whether a DOT system is in place, what patients' adherence is like, what treatment-seeking behavior is like. Do patients go to clinics versus hospitals, as our previous speaker has mentioned? So being able to contextualize all of this within the public health system and take this biological information, translate it into mathematics, and to synthesize this information to provide some meaningful and useful recommendations is really what disease modelers do. So those of us who worked with the COVID-19 epidemic, this wasn't our first, though many of the public had perhaps heard of our institutes and ourselves as disease modelers for the first time during COVID-19. We have actually been supporting the South African government and governments around the world with a variety of other diseases over the last 10 to 15 years. So we as disease modelers are not necessarily just specialists in one disease, but often apply our trade to a variety of diseases. So speaking for myself, I've applied the majority of my work within the malaria sphere, within different strains of malaria, which really behave like different diseases all around the world, from Vivax and falciparum malaria acting together in the Asia Pacific, as well as competing with each other in South America, to say falciparum malaria, which is the malaria that we see throughout Africa. I've been working with over 20 countries in trying to design their malaria policy in the last 5 or 6 years. Likewise, I work in pertussis, so in vaccination. Pertussis, if you don't know what that is whooping cough. So I work with the National Advisory Group on Immunization in South Africa to design models to look at the impact of different vaccine boosters and vaccine strategies to combat pertussis. And likewise, working with another vaccine-based disease like hepatitis A to actually measure whether we should be including a virus against hepatitis A within the South African treatment protocol. So our experience in working with a number of diseases gave us a good background when it came to applying our skill set to COVID-19. But we were still faced with a really, really tough space to be in, because there really wasn't much known about COVID-19 globally as well as locally. And so what we had to do, our sort of additional skill set that we had to apply during the COVID-19 epidemic in South Africa, was being adaptive, was being able to adapt and build and rebuild our models and trained them to new knowledge and data as it was emerging almost on a weekly basis since March in this epidemic. We weren't alone locally, so to speak. It wasn't just entirely a South African perspective when it came to modeling. At the start of the epidemic, at the beginning of 2020, I was called to be part of the WHO modeling task team, where we jointly with other teams, all of modeling teams around the world, would be looking at the epidemic as it progressed in Wuhan and then moved into Europe and then down into Africa. And so our modeling work was almost continually communicated with other modeling teams around the world. So you may be aware that around about May, we published our first model. And the question we had to ask ourselves was really, at the start of an epidemic, when you know almost nothing about how the epidemic and how this virus works, let alone how it will manifest in Africa, we had to choose what modeling method we would be using. Should we be going with statistical prediction method, where one trains your model to data only without really considering the underlying causes of deaths and cases? So just do a model fitting exercise or a curve fitting exercise at the start of the epidemic. And of course, that was ruled out entirely for the simple reason that we had no data. So there was no curve fitting to do at all. But secondly, we ruled out the method of curve fitting because we were trying to model the disease pathways through the health system to measure the impact on the health system. So just merely predicting cases using cases themselves or predicting deaths was rather a function of the underlying system and testing strategies compared to what we wanted, which was a causal analysis. And so we looked at other modeling methods like compartmental models, metapopulation models, agent-based models. And again, we made a decision to move towards metapopulation models. And this was in favor of agent-based models because, again, agent-based models are very data-driven models, or they should be very data-driven models, where knowledge is required at a very fine granularity in order to properly train your model. And so in the absence of data and with the great uncertainty in understanding how the disease works, we opted for simple models. And the metapopulation model that I speak of is a compartmental model where we look through the flow of the population through various disease states over time, but at different populations in space. So the first model we developed was a provincial-based model looking at the 9 provinces and how the disease would manifest in the 9 provinces. So a compartmental model for each of the 9 provinces, and that becomes a metapopulation model. But when we release this first set of projections, anyone who's read our report will realize that it's quite wordy and we had a lot to say about these projections. And this is where context, I think, is really, really important, that people look to models to be providing you with an answer. They look to it as if it is basic science in informing, in saying this will be the number of cases, this will be the number of deaths without much uncertainty. But actually, in what we're trying to do in synthesizing data across the hospital space, across the biology space, the public health system, and trying to bring them all together in a model, we are in fact building a model of models and incorporating the uncertainty of all the component parts. And so context becomes extremely important. So when we first made these projections in May, it was on the back of 0 local level data. At that point, we were still, there was no data on locally on the hospital care system, on the pathways. There was very little representative data on testing strategies were different across the provinces and across the public and private space. And so we had no real local level reliable information on which to base our models. And so we looked to the experience in other countries in Europe, the US at the time, and China in order to inform our models, in order to provide perhaps the best prediction we could make at the time in the absence of any local data. In May, we had just come out of the first level 5 lockdown, and there was not enough information yet to even estimate the impact of the lockdown, given that the lead time between infections, incubation period of people accessing hospital and some people dying. Our models have always projected the need for services. And one of the things we have, and the reason for doing this, of course, is that we were trying to support planning. And planning, or one should be planning on need for services rather than what would be the actual use, in order to assist with to reduce the likelihood of running out of services. And so we acknowledge that a utilization of services were likely to be lower. And once again, what makes COVID-19 different or more difficult to model compared to other diseases is that there's no treatment and there's no vaccine. So those are not controlling interventions that are really the primary reason why our disease is at a certain level. COVID-19, however, was governed almost purely by population behavior and adherence to non-pharmaceutical interventions in terms of its rate of spread and the access into hospital and so forth. And now we could look to flu data, which would suggest, some studies have suggested in the NICD, that in South Africa, that in, I think it was 2017, only 42% of flu-related deaths were medically attended. So one could look to that to be an indication of attendance at hospital and use of services, but at the same time, COVID-19 was not flu. We used to flu being quite low on our radar as a population when it comes to diseases, but COVID-19 was the number one priority for majority of the year. And so it was likely that utilization would have been much higher. Likewise, when looking at estimates of severity in hospital, in South Africa, it was quite likely that our criteria to enter hospital and ICU are far more strict than European nations and other nations across the world. So these were all factors that needed to be contextualized when it came to interpreting our model projections. As I mentioned about adherence to non-pharmaceutical interventions, behavior changes in response to the epidemic were not something we could have modeled right at the start of the epidemic. Now, when we talk about behavior changes in response, we're talking about how the epidemic becomes personal to people and how that impacts your behavior. So, for example, as we were receiving daily reports on deaths and on cases, and in your area, as deaths and cases increased, this would have instilled some kind of fear into you, perhaps, and altered your behavior. Perhaps you're wearing masks more often or socially distancing to a better degree than previously. As soon as many of us knew someone personal who had either had been admitted into hospital or who had passed away from COVID-19, it suddenly brought the severity of the epidemic home. And these are material changes in behavior that actually alter the course of the epidemic. We've seen it before in the Ebola epidemic, where response to high mortality was the primary driver in changing the trajectory of the epidemic. And it is likely that it had some role to play in our COVID epidemic too. And one of the difficulties at the time is that we still had to support decision making and provide budgets to measure the costs and the impact of the health budget for COVID-19. But even at a time when we didn't know much about the disease and how people would access hospitals, but also we did not have any idea on the ingredient costs that would be charged or would be available to South Africa at the time of providing these budgets. So there was one word that I think we've mentioned more than any other throughout this epidemic as modelers, and that is uncertainty. We were surrounded by uncertainty in almost every aspect that we had to model, and yet we still had to provide results. And so I mentioned that we had to continually update. And so as soon as some local data started becoming available, thanks of course to Vula Mobile as well for assisting in this procedure, as soon as this local data started becoming available, we were able to expand our models, expand our hospital pathway, develop something a little more indicative of what was going on in hospitals, and at the same time taking into account that there were new drugs that were in play. The doctors in the Western Cape, having experienced the epidemic first, were making innovations fast in how they treated patients. This was altering death rates, and so we were able to adapt our models as a result. But no sooner had we made one adaptation to the model, a new set of data emerged, or the stakeholders, the government, and the different facets of government who we were trying to support had differing needs, which meant that we needed to change our models yet again. And so after the second version of the model was released, we had to almost immediately start making another change. And one of the feedback we got from the provinces is that fine and well that you are providing decision support at the provincial level, but we need to know what's going on at the districts. Our districts are behaving in they're not behaving in the same fashion as the provinces. We need to tailor our responses at a district level, and in terms of building field hospitals, ordering oxygen, and so forth. And so we had to then suddenly expand our model. And as you can see on some of the GIFs playing on the right-hand side, that there was considerable heterogeneity in the districts. Now, one of the difficulties posed to us at the time is that in this meta population of provinces, during up until June, July even, there was no interprovincial movement that was allowed. And so it was all right in our models to keep the provinces separate. But if we had to move to a district level, people could still move between districts. And so we had to capture this connectivity, this mobility between districts. And so at the time, one of the mobile companies, Vodacom, gave us access to their data. And what you see on the left-hand side here is mobility over the period from April to June. Just connectivity showing between the different provinces and districts in South Africa, with increased movement in the green on weekends, and changes in movement depending on the lockdown stages on weekdays. And so we took this mobility data and we allowed it to infer connectivity between the districts in order to provide a set of district projections. And this allowed us to measure, to assess capacity constraints within the districts of South Africa, as well as how movement between districts could assist in not having excess deaths and so forth. So the bottom line is, even after this version 3, we've had a version 4 of our models and a version 5 of our models. And these models have to continually update as new data becomes available, not just from the NICD, but from other partners like the SAMRC, for example, when it comes to the excess mortality data, and surveys that are being conducted, surveys from the SAMRC, analyses or the NICD on the RT, and how the epidemic has evolved over time. The longer we wait, the more data we have, and the more data we have, the better our models can be. The difficulty, of course, is that decisions need to often be made 6 months in advance, and that's the difficulty of having to develop these models at a time with very little data, but still trying to provide robust conclusions or robust projections. So who are our stakeholders? Where did our models get, who did it get communicated to? And the list of stakeholders is quite wide, but I'd rather just discuss the areas that we supported as a modeling team. We supported the Ministerial Advisory Committee when it came to providing scenarios on the impact of certain interventions, or on just the course of the epidemic in general. We assisted teams on preparing facilities and the expansion of facilities, assisting with projecting the staff numbers that would be required at different times of the epidemic, and shifting in staff that could occur to support capacity. We assisted the ventilator project and the planning of oxygen, particularly in resource-poor areas like the Eastern Cape. And looking at the designs of supporting emergency services to bring patients to hospitals, especially in areas where there aren't ICU facilities or well-equipped hospitals in poorly resourced settings. We assisted with this. We spoke to the teams who were ordering drugs to be supplied to hospitals and clinics over the course of the epidemic, as well as informing testing strategies and ordering of diagnostic kits at different times in the epidemic. Likewise, the planning of isolation facilities and the placement of mortuary containers. And we also assisted the national and provincial treasuries with forming the COVID-19 health budgets and executing these budgets across the country. So the question on everyone's mind around about now is, what about the second wave? And I like the example that was given at the previous with the previous speaker on. We talk about a second wave, perhaps there's multiple. And as modelers, we also caution similarly that everyone is worried about the second wave, but perhaps we need to think more long term than just next year. What will COVID-19 look like over the course of the next 10 years? So the first question we ask ourselves is it really going to be a second wave? And this is where language becomes important. That there are words like a second wave, or phrases like second wave, resurgence, uptick, upswing. What do these things actually mean? So here's just a few examples, just taken from the publicly available World in Data, but shown at the end of August for illustrative purposes, demonstrate the difference between a second wave, resurgence, and uptick. If you look at Spain here at the end of August, what you see there is a clear second wave where there's some threshold shown by the horizontal black line below which the first wave had progressed, and then we see that there is an increase in cases that surpasses a threshold yet again, and that is what we can see as a distinct wave that is separate from the first wave. And you compare that to a resurgence, which is what we're seeing in the United States at the moment, where the first wave did not really decline significantly. As you can see that there's the dotted horizontal line being a threshold here, that we see that the epidemic only had a little blip of a decline before it started increasing again. And that is what we define as a resurgence. Whereas if you look at Italy, what we're calling an uptick at the time here at the end of August is the start of an increase in cases, and you do not know yet where that could head. It has passed the first threshold on its way up. If it passes the second threshold, then we're looking at a series of increases, which is what we call an upswing, which could become a second wave. But at that stage, at the end of August, increasing just a little, it brings about and it's an alert mechanism that, look, we could be getting a second wave. We cannot classify it as a second wave yet, but perhaps interventions that are implemented now, better communication with adherence to non-pharmaceutical interventions and so forth, could prevent a second wave. So the question is, what does that mean for South Africa? And if we were to chart our current epidemic, we are quite into a decline. That what we will see next time around is probably not going to be a resurgence, but actually a real second wave. But again, what is that nature of a second wave? And that all depends on vaccines and therapeutics. Now, if we look at therapeutics, we know that there's no cure yet for COVID-19. There's also no fully licensed treatments. That the FDA has granted emergency authorization to 5 treatments as at the 30th of September. But there's at least 310 plus trials that are underway regarding treatment. So we hope to see new treatments and fully licensed treatments in the coming year at least. On the vaccination side, there are over 140 teams with more than 200 candidates in development. In preclinical trials, we have over 140 trials underway, 0 vaccines approved, but 11 trials or 11 trials in the phase 3 phase of control. But the timeline for the vaccines is still uncertain. The aim is that there might be a vaccine by the end of 2020, mid-2021, yet even from organizations like Gavi and so forth, there were talks of perhaps only getting a vaccine at the end of 2021. And when a vaccine is in fact released, we know that there are likely to be challenges with constraints when it comes to production. There may be chances of hoarding and difficulties in implementation. Already we know that there are market mechanisms in place to try pooled procurement or equitable distribution of vaccines. And these are all talks that are happening currently. I know that there was a recent talk when it came to immunity, so I won't go too much into detail. Safe to say that there's a lot of research underway and a lot of uncertainty too. We've read about antibodies and the presence of T cells, memory cells that can be detected during and after infection, but the presence of these antibodies and T cells are not enough or do not guarantee immunity. The real question is what protective mechanism is conferred by the presence of antibodies, T cells, memory cells, and so forth. And what does that protective immunity actually mean? What is its nature? What is its duration? And what is its strength? These are all the key questions that are hanging in the air at the moment, and they are deeply impactful when it comes to vaccine development, but also in terms of modeling for what a second wave might look like. Could we have natural immunity that lasts lifelong? Or would it only last a few months or a few years even? Could it be, say, something similar to influenza or pertussis even, where natural immunity only lasts 4 to 8 years? All of this we do not know, yet research is underway. So I thought it would be nice just to engage in a few scenarios. So here's scenario A, where we look perhaps over the next 10 years. What if we had a short duration of immunity, say something like 40 weeks? So immunity either driven by natural immunity, so those who have had the infection before were given 40 weeks of immunity or protection against infection. Likewise, a vaccine also providing 40 weeks protection. If that were the case, what would we expect in the long run? We would expect annual epidemics to be occurring, though with a smaller peak than our initial peak. And what this means is that COVID-19 would become a regular occurrence in our lives, something we learn to just deal with every year. Like it is flu season, it becomes COVID-19 season. And that's with a duration of immunity of around 40 weeks. But what if there's a longer duration of immunity, either vaccine-based or natural-based, say something around 2 years? Then we could expect epidemics to happen every 2 to 3 years, but with far substantially lower peaks than the first time round. So it would not necessarily be regular, but we would experience, we still be able to plan adequately for these epidemics that would be occurring almost regularly every 2 to 3 years. But what if the nature of immunity was not to be protective against infection, but protective against disease? Now, what that means is that everyone would still be able to get SARS-CoV-2 again, but you would not get the disease, as in you would not fall sick and have symptoms, either mild clinical symptoms or even severe symptoms. Now, if that protection against severity of symptoms is conferred by immunity, and let's say we're looking at a 2-year period of immunity, we could find that COVID becomes a regular occurrence every 2 years, but the impact on the health system is much reduced compared to what was experienced now, simply because there's protection against severity. It just becomes a mild cough, flu-like coronavirus that we learn to deal with, with very few admissions and deaths occurring. And this impacts greatly on how we plan as a hospital system for COVID-19 in the next decade. And so scenario D, what if we had some cross-immunity with other seasonal coronaviruses shown in orange, with COVID-19 shown in red? As soon as we have cross-immunity, the dynamics of infection become quite variable. And so we could expect perhaps a 2-year gap till the next COVID-19 epidemic. But thereafter, we would have small but variable epidemics every 1 to 2 years. And the less predictable these epidemics are, especially in terms of their size, the harder it is to plan for. And that would be something we would need to take into account. Now, as time progresses, we will have a better understanding if cross-immunity does exist and what the nature of the epidemic is likely to be. But otherwise, planning still needs to happen, not just from a health perspective, but also from an economic perspective. So in conclusion, what are the long-term considerations that we have to take into account? I think lessons learned from a health system perspective, we have to invest in data for decision support. And this also highlights the importance of mechanisms like William Mapham presented in the previous talk. We need better cluster surveillance. We need to be able to link our data systems in a better way that we can get good quality, representative public sector data quickly, and this will help to develop our models and will help with when it comes to real-time decision support. If we want to create an alert system for a second wave, we can't do that with data that is perhaps a week or 2 weeks old by the time it gets to the decision support mechanism. Likewise, in terms of hospital preparedness, we realize in this epidemic there's work to do. We have to think about the fungibility of wards, like in hospitals where we have TB wards that are, wards dedicated solely to TB at different times of the year. Would we need COVID-19 wards? Could hospital wards be changed? Could they be fungible enough to cater for the needs of the different disease epidemics at different times of the year? Likewise, having beds is not enough. We need fully equipped beds with oxygen supplies, but also health workers to service these beds. We need adequate emergency services in order to bring patients who cannot access care to hospital. In terms of the flow of money, I think we could always do better with a better national provincial coordination, and this will support procurement flexibility, the ability to order goods as and when they are needed, rather than being tied down by red tape or the unavailability of funds because they haven't moved yet between the different mechanisms of government. As modelers, what are we busy with? Well, no sooner had the first wave shown to be on a decline that we already are modeling a second wave. We are looking to model vaccine allocation in order to prepare the systems for when a vaccine does come, given its efficacy, given its protective mechanism, how might we roll it out? Who should be prioritized in terms of different risk groups, and what will that implementation mechanism be for vaccines? And likewise, we're working with the national government to plan for the second wave, to create alert and response mechanisms and triggers, thresholds that we should be using to keep an eye on a very fine level of areas within the country to allow for an adequate response. And we're also working with teams on designing economic resilience strategies based on the future outlook of some of these scenarios that we presented today for COVID-19. So with that, thanks very much once again for having me at this forum, and I'm looking forward to your questions. Thank you.
Sheetal, that was, oh, sorry, I've got some background noise here. That was fantastic. You did not disappoint, as I knew you wouldn't. Thank you so much. And I know you've been under a lot of pressure because this is not the only thing that you do, right? You still got all of that malaria work going on and all of those kind of things. So thank you for taking the time. I really do appreciate it. Your fandom has increased. I've been getting messages to ask for introductions and all of these things. So I know it's not just me that has a sort of biased view. I'm going to abuse privilege quickly before I hand over to Griselda to go through the questions and just ask one question to start with, because the second wave issue is receiving a lot of attention, as you know, and as you also know, not uncontroversially so in the actuarial community. So, just looking at the data sort of, every day, every second day, looking at how second waves are manifesting in Europe. I mean, the US is a special case because it's very geographically spread. It was first the northern states and then the southern states and those sorts of things. But in smaller countries like Europe, Western Europe countries, Spain, Italy, etc., the second wave phenomenon is much more observable and less affected by geography. I think that the big issue seems to me that there doesn't seem to be the same relationship between cases and deaths as there was in the first wave. And so it sounds very much like your sort of scenario C, that the immunity is at least lasting long enough to protect people in this in the second wave of cases. The deaths don't seem to be there at all, except for very specific countries like Israel, which is having a very rough time at the moment. And it seems to me like that's because they didn't have a proper go the first time. So they held the infection spread at bay, which everybody thought was successful that first time around, and now that it's come back into the community. So it feels like it hasn't run its course. In South Africa, what gives me hope is the seroprevalence studies that were done by the Western Cape, where there's deep penetration of antibodies in at least in many of the communities, not in all. So that gives me hope that if we do see a second wave of cases, we're not going to get anywhere near that. We should get off lightly from a death point of view. So maybe if you could just have a go at that particular question, and then Griselda, if you could take over the rest. But thanks again, Sheetal, for taking the time.
Thanks, Barry. So it's a really interesting question. So when it came to looking at the second wave idea for South Africa, the first thing we did was to try and investigate what's going on in other countries, and importantly, who's actually getting infected in these second waves in Europe, for example. And one of the things we're seeing is that in some countries it's different people. It's not necessarily the same people who are getting reinfected, but different people getting reinfected, and different groups of people. So, for example, in many European countries, where we're seeing with opening up of relaxing of restrictions, people getting back to work, life getting back to normal, people traveling, a lot more younger people are getting infected, which would mean that the severity of infection would be lower. Secondly, we've learned, haven't we, over time? With remdesivir, with dexamethasone, and a better understanding on how to actually treat and triage patients over time. Europe is having a better deal of managing patients now than they had to learn the first time around, when there was very little information on how to treat patients. So taking these, taking those things into account, and then of course looking at seroprevalence. I think seroprevalence really is the key. The key here, that in many of the European countries, I mean, even places like Spain, looking at a seroprevalence of around 5%, and then you compare that to some of the numbers we're seeing in South Africa. Of course, we must acknowledge that even in the Western Cape, the seroprevalence samples are not exactly representative of the entire area, let alone the whole country. That they are convenience samples, but we are still seeing a far greater penetration of SARS-CoV-2 compared to other countries. And what that should mean for us is that if we do have a second wave, it is likely to be lower and with a low severity. And of course, much depends on our behavior. So I think it's important that when we look at any country experiencing either a resurgence, a second wave, upswing, and so forth, we have to ask, who's being infected, where are they being infected, and do they belong to a particular risk group that could impact on different death rates than the first time around.
Thanks.
Thanks, Giselle.
Thanks. Maybe just another question there around the second waves. Also, a few questions coming around testing. So, you know, maybe there was a shortage of tests initially, and, you know, now it's rather a manifestation of increased testing. Do you just want to comment on that?
So I'm not quite getting the question.
So it's a question as to whether we're seeing these increase in infections or second waves just because there's more testing available now. So rather an increase in testing than an increase in infections.
Well, it could be the case that I think obviously with more testing you will find more infection, but it comes down to test positivity as well, and trends in test positivity. When we're looking at second waves, you don't just look at the number of cases, because that is a function of testing strategy alone. You've also got to look at test positivity, and so trends in test positivity, where perhaps it has declined over a first wave and now we're seeing increases in test positivity. These are the real signals that we need to look at in assessing second waves and resurgences. I think it's the one thing we do know in this epidemic, that you can't just look at cases alone. You can't look at deaths alone. You have or admissions. You've got to look at everything together to try come together to try paint a picture of a situation.
Okay, and then Gary also has a few questions for you. I think let's maybe stick with you since you have the mic. So Gary, do you also want to address your questions?
Yeah, thanks, Isolde. Fantastic presentations from both speakers, you know, and they just throw up so many questions. I didn't really know where to start, but maybe with William, you know, first of all, you know, outstanding way that Vula has sort of stepped in and offered all kinds of services based on its existing platform and maybe into the future. So my question was, when you look at Vula's success in providing more or less essential services, information services and referral services into the public sector, what does it say about, you know, private-public collaboration and the role of a private entity and its, you know, related governance, accountability issues for the future? You know, is this going to be a kind of model for the future? And when I put the question into the chat, I think you kind of almost preempted it at the end when you said that it requires, you know, universities and private and maybe business and public to come together. So I guess, William, an invitation to just to say something about how, you know, this collaboration can work. Is it a precursor to a better system, NHI, etc., all of that? And then, yeah, I'll stop there. Thanks.
Yeah, thanks for the question, Gary. I think if you look at you asked about the challenges of how Vula was developed. If you can imagine issuing a tender from the government saying, we're not sure how you're going to do it. Here's 6 million rand, you figure out how to do referrals. And that was your tender. It's highly unlikely to get a productive outcome. You might end up with a lot of money being spent, but it's hard to imagine how that would happen. Typically in the Department of Health, or in the private sector, they buy software from outside and try to implement it in the system. So if you look at public sector, that's happened a few times. Even if at Discovery, they bought HealthTap and brought it in rather than trying to develop from the ground up in South Africa. I think with Vula, we were very lucky to get enough funding to try and solve the problem from the bottom up. So using a more sort of what we call an agile response. And it took us 2 years to really get any traction, but it meant that we learned every single month about how to actually solve the problems. And we're still learning, we're still releasing new features to solve the referral issues. So I think the advantage of going from the ground up is that you can develop a system that works. The disadvantage is it's very hard to get a tender from the government for something that you've developed from the ground up. So we have battled with that, and that's why we've gone to the public sector, to the private sector, to the universities, to find partners who can make it work and actually want to create the coordination that's necessary for the NHI. I think a lot of people think the NHI needs more money, However, I think it actually needs perhaps less. If we just coordinate the responses and the amount of resources we already have, I think we can do quite a lot. For example, at Kimberley, if you go there, the private hospital is literally next door to the public sector hospital. The OCT scanners, which are used in ophthalmology, are not used on weekends. So you could easily put the patients through to have their tests in the private sector hospital, and they get seen the next day in the public sector hospital. So I really think we're really blessed with a huge amount of health resources in South Africa, and it's how we make the most of that. And hopefully we can play a role in that. You asked a question about the private GPs on the chat as well. So about 15% of our users are private GPs. I can give you an example. My wife had a skin condition, something on her forehead. So we tried to get an appointment with her for a specialist in private. It took us, the fastest appointment I could get was 6 weeks. And so when she went to see the dermatologist, I had no feedback. So as a GP, or pretending to be a GP, I was none the wiser. We tried it on Vula. We got a response within 15 minutes, and it was another lesion that can require over-the-counter treatment, and I learned from that case. So I think the private sector GPs are often using Vula to get information from the public sector, from a specialist, and treating their patients better than before. The other example is from Mitchell's Plain, where the GPs would typically write letters and say, please go to Mitchell's Plain, and they would get no feedback, and the patient would pitch up for the letter, often turned away because there's actually no appointment being made. So Vula's been used there to coordinate between the private sector GPs and the public sector hospitals quite efficiently now. So patients don't just pitch up, they actually pitch up at the right time, on the right day, and they can actually be seen. You can imagine taking a day off work when you're poor. It's very expensive to be poor. You can't take a day off work just to fish panado. That's just ridiculous. So I think we've got a lot to do in terms of really helping people get the best healthcare in the best possible way. I think Guy's question also talked about the private sector hospitals. And it is hard to know how much it would cost to put a public sector patient into a private theatre with a public sector surgeon operating. I think what we're going to have to do is use the agile approach again and do it. Take a weekend. Take it when you know the theatre's empty. Run it for a month. See what it actually costs. And then go to the government and say, look, this is how much we saved. And I think then with public working together with private, with the academic institutions looking at how the impact has changed, I think then we can actually create the coordination necessary to create an NHI that works. So I'm full of hope for the future. I think coordination is the key.
Thanks, Dr. William. So then we also have a question from Matt Zalstra for you on whether you're planning on adding any electronic medical record functionality to your platform. So e-prescribing and referral for pathology and radiology investigations.
Yeah, so we're always adding. Typically, it's 1 to 2 specialties per month. So soon the bookings at Groote CT scan and MRI will be done through Vula. So that's kind of one example. Pathologists have asked to be added as well, because often the samples are sent inappropriately and they just need to get advice from the pathologist. So that's all, we're adding all the time. We're always learning from the specialists using Vula. I think Sarah asked if I know Dave Stead, and with 15,000 health workers on Vula, one of my favorite parts is meeting all these dedicated health workers in the health system. I think there are some really truly incredible people out there. Vula is used as a part of the medical record. So there are 101 hospital record systems, but there are not that many referral systems. So the Vula system is used to import the data from the referral into the medical record, either as a PDF or on our own online dashboard. So I think we're part of the system, not trying to replace the whole system.
Thanks. And then I think Christoph also has a couple of questions for both speakers, I think.
Thanks, Griselda. Sure. No, let me start by just thanking both speakers and all attendees. Of course, we're always humbled to see everyone attending these events. But maybe just before I ask my question is to Sheetal, but before I do so, I've noticed a number of chats asking about the availability of these presentations. That both were quite dense and informative, and I think some people would like to look at these again. We are recording right now, and the entire session, the video and the audio and the presentations will be available for download just a little bit later today. we also, if you want to ask a question live rather than having Griselda read it, we would prefer that actually, because we all need a little bit of human interaction, like if you can call this face-to-face, we need more of that. So if you want to ask a question live, Griselda can just give you permission to share your video, and then we can have a bit of a conversation rather than just reading questions. In any event, Sheetal, I guess my question is a little bit selfish. I'm not as actively involved in the modeling community as Barry, and certainly not as involved as you are. But maybe just by virtue of being an actuary who's close to healthcare, I get this question more often than not, hence the selfishness, is, initial projections. If I think back to March, Feb, the Imperial College of London suggested millions, tens of millions of cases in some cases, fatalities ranging into the millions. And of course, today everyone appears to be an armchair epidemiologist and an expert. Everyone knows better, and hindsight is 2020. And I'm sure if I get this question as often as I do, that you would get it too, like even in dinner conversations. How could the professionals get it so wrong? And this are sometimes politically motivated by people who believe that lockdown was unnecessary, etc. But I think it would be really useful if you could just maybe reflect. You've certainly given us a sense of the complexity of this, but I would love to just hear your reflections on a high level. Like, what would you say were perhaps the unexpected features of the pandemic that resulted, without discounting the severity of what we've gone through, but that resulted in the deaths and the number of active cases being perhaps an order of magnitude lower than initially expected, if you felt more than that? I'd love to hear your response to this question. Thank you.
Sure. So, right at the beginning, if you think about what is the most logical thing to do, you hit with this epidemic in this new unheard of coronavirus, and 31st December 2019, and you now have to make some projections as to what it's going to look like in China. You've got initial work on the ground. I'm telling you, at least my response, should I say, is informed by my discussions with the modeling teams like Imperial, CMMID, IHME, all those working on the ground in China, in Hong Kong, and Asian experts. And right at the beginning of the year, you're at the point where you say, well, we have to look to other coronaviruses. Could this one, it's a coronavirus, could it be similar to SARS? Could it be similar to MERS? Could it be similar to your flus? At the same time, there are people on the ground doing an R0 analysis, as in they're looking at calculating serial intervals, looking at when the disease transmits, what's its infectious period, is there in fact pre-symptomatic transmission? And then you put all that together and you use you look at SARS and MERS and you apply those parameters to a model. In the absence of intervention, what you're going to get are predictions of millions and millions of deaths. The question is how that information got interpreted, and in many ways misinterpreted, that you have to take context into account, like I went at great lengths to explain. Yes, these are projections, but we don't have this, and we don't have that, and we don't know this, and we don't know that. So technically you could be anywhere, but if we were to base this on the best knowledge available, this is what you're getting. And that's basically what modeling is, what it was then, and how it's evolved as we've known as the epidemic has progressed. So that addresses, I think, my opinion on the initial Imperial College estimates. And I think they've shamed. I think they've had a bit of a bad rap, because I've seen perhaps equal, a great deal of misrepresentation and misinterpretation of modeling output in the scientific community, in the press. I think it's really gone viral as to what made models famous and infamous. I think a lot has to do with proper communication. So that's definitely one of the lessons that I've learned in this epidemic, is that the next time round, when we do have another epidemic, I'm going to hire a PR person who can sit and either tweet for me or be publishing, or on a weekly basis updating the population on what's actually happening, what the models are doing, here's our assumptions, because for this time around, we really just did not have the time to engage in this level of public engagement. And had Imperial College and other teams also had the availability of such resources, it would have also helped them, I think, at the time, and just better communication of model results all around the epidemic, not just South Africa, but really worldwide. But then to address your question on the surprising elements, and I think in our sense, in South Africa, what is, I wouldn't call it a surprise, it's something that we knew we weren't taking into account, but we also didn't know how we were possibly ever going to take it into account without data, was the public response to public behavior in terms of the people interacting with each other in differing manners, heterogeneous behavior, public response to mortality. And I think that's really what has shaped the epidemic. At the same time, the low utilization of services has been surprising, given the popularity of, well, not popularity is the wrong word, but just given how the awareness of COVID-19 compared to, diseases like flu and so forth, one would have expected a greater attendance at hospital facilities. And why I do feel that this is necessary is because if one does look at the excess mortality analysis that does where excess deaths are increasing at the same time as the exponential increase in our epidemic, and decreasing subsequently at the same time as a decline in our epidemic, and knowing that we have a huge problem when it comes to reporting, that the data systems are not linked, and deaths in and out of hospital are not necessarily reported, though they may have been COVID-19 deaths and these kinds of things, that there's that people who should have come to hospital weren't coming to hospital. So I think that that's also been something that's quite surprising. But what this has helped us do is collect data on public response to epidemics like this. We never, if you look at countries like Sierra Leone and so forth, who've been through an Ebola epidemic, you have an idea of how your population will respond to when it comes to the adherence of NPIs, or when it comes to responding to an epidemic. But in South Africa, we've never quite had that. So what this first round has given us is data that will allow us to do it better as time progresses. But I do think that better communication all around for us, as well as the entire world modeling community. I think as a community, we all agree that better communication is necessary.
Good points, thank you. Maybe just again, while you have the mic, I'll give another question to you. And just for our attendees who are still on, this will maybe be the last question, but we'll still stay on if there are people who still want to maybe engage and just talk and still listen to questions. But I'm sure some of you have some other engagements. We did schedule today until 10 o'clock. So just one more question for you. If you were the minister or president and you were offered 4 different projections from 4 different modeling groups, how would you choose between them? Bit of a political one again.
Actually, I think I was asked this question, a similar question by the press. I think modeling is about scenario analyses, and if each of these models are providing a different scenario, you don't choose between them. You look at each scenario and look at each set of projections, and you take into account how those projections affect your response from a health perspective, from an economic perspective, from a social perspective, and you tie all this together. It's basic scenario analysis. So I don't think that there's a choice of one or the other, unless of course one model is making entirely, is not useful in terms of planning, or is not making correct assumptions, or doesn't have the right data underlying it. Aside from all of that, if we've got 4 robust models giving 4 different sets of projections, they need to be contextualized, and we need to choose a course of action that could hopefully be robust to the different model outputs.
Can I jump in there, Griselda?
Sure.
It was my rude question, or provocative question, Sheetal. In that, there's no question about your technical expertise and others, the actuarial group and the other group. I guess the it's the decision-making pathway that is really needs some scrutiny, you know, to get from the expertise through to a good decision. And I think some of us are concerned about the breakup of the Ministerial Advisory Committee and its reforming without very much transparency around that process, and whether we're going to get good or better decisions going forward out of the structures that are now put together. So do you have any reflections on how the country can, you know, get better decisions out of the expertise that's available, such as yours?
You know, I think that's been the benefit of having a group like the modeling consortium and having this wealth of expertise to you know, to help support decision making. We're not the ones making the decisions; we're the ones providing evidence, and that goes for all groups, whether you're on the Ministerial Advisory Committee or on, you know, and I think I found the channels to provide this kind of this kind of scientific support open, but again, we're not the ones making the decisions. I've worked in countries all over the world, and I've always said that South Africa at least has been open to science in a way that many countries are not, and I think that's impressive. When it comes to the Ministerial Advisory Committee, there was always the notion that this committee is fluid, and that it needs to be adapted. As we've seen new committees being creative now with respect to vaccines, and then with respect to social behavior, and so forth. I think that as a public who is aware of what of the advisors to government, and then who's part of the Ministerial Advisory Committees, as well as the advisory committees publishing their advisory statements, I think that is one way in which the public can keep abreast of who is advising government and what are they saying.
Thanks. Having said, it was tremendous, excuse me, to see the proceedings being published, but it was 3 months after they had taken place. So.
Yeah, it's not
it's a
ideal.
Step in the right direction.
It's a step in the right direction. It's not ideal. We all have. We all have our gripes. I'm the eternal optimist, however, I think, and so I do try to look for the good in everything. And I'm glad that we as scientists are able to support and work with a government who is open to receiving their support.
Thanks. Maybe just another question for Dr. William. I think you did touch on this a bit, but maybe you can just take a look at this one again to speak more about your experience in terms of linking private doctors and public theatres and hospitals to reduce waiting and transport times. And is there an appetite, and what are the hurdles encountered there?
So yes, there's an appetite. We've seen, especially in the areas around tertiary hospitals. For example, if you take Tygerberg, for example, ophthalmology, my own specialty, about 30% of the referrals are from private optometrists because they know that if they use Vula, that their patients will get appointments for elective cataract surgery, which they can't afford in the private sector. So there are multiple examples of how the private sector is actually using the public sector as a resource. The private GPs is another example. If you take, for example, in Khayelitsha, the GPs in the sort of township area are able to make appointments with different departments at Khayelitsha Hospital for general surgery, gastroscopies, psychology, and so on. So multiple specialties. So I think there's actually a high degree of existing collaboration between the public and the private sector. I think during COVID, we actually saw a spike. So we went up from between 5 and 15% of interactions on Vula being in the private sector. And that went up to 25% during the pandemic, and that's now gone down again. So I think the pandemic kind of created an opportunity for us all to network and to work together. I think going forward, we're going to have to go back there and actually work out how that happened and make sure we form better connections in the future. Some of the challenges are that the waiting lists at public hospitals are long. So for example, you might wait 6 months for elective surgery. And one of the challenges there at Tygerberg in my old department was that we'd be cancelling elective surgery cases to do trauma cases. So again, if we can decant the trauma cases to empty theatres and private, it'll enable more people to get elective surgery. So I think there's a lot of room for improvements. But I think there's a lot of existing collaboration between the public and private sector, and we need to carry on increasing that.
Thanks. So that was Dr. Odwa's question. I did promote him to a panelist, so he might just have another comment for you there.
Thanks. I'm going to flip my video in. Okay, that's my background. Hi, Dr. Thanks so much, and hello to a fellow Eastern Caper. Do you hear the willingness to do it? A guy who came on, who was commenting, Guy Delbo from Mediclinic, I know has been trying to really get his theatres to do that, to go into the public-private partnership. And he's saying it's fraught with difficulties. And I was just wondering if you had seen that, not have, but if you had seen that on your side and what you thought could probably bring an end to that. Again, just to sort of decant those cases that can be done in the private sector to be done there, and sort of free up, the public sector to do those cases that cannot then be moved elsewhere.
Yeah, so I think we've all identified the potential, and you've got empty resources, or theatres anyway, sitting there, highly equipped, highly efficient, just waiting to be used in my mind anyway. And I think what we're going to have to do is, rather than working out all the fees up front and doing a fee for service from the very, very beginning, I think we actually need to go for it and do it at our own cost, at least for the first few weekends, to work out exactly what are all the obstacles, because obstacles might be small things like transport from one hospital to another, like which ambulance is going to drive the patient from the public sector hospital to the private sector hospital? Where does the patient go afterwards? Do they stay in the private hospital, or do they go back to where they came from, or do they get decanted to the tertiary hospital? So I think there's a lot of very small details that need to be worked out, and sometimes it's hard to guess at those in its entirety before giving it a go. So I would definitely start off with kind of a minimal viable system. Maybe take one theatre with a common condition that can be commonly done in a theatre, for example, whether it's an abscess or whether it's a cataract surgery, and do it at our own cost, at least for a few times, to show that it's possible. I think once we've shown that it's possible, then finding the money might be easier, whether it's from the private sector, the public sector, or through an academic research budget. There's lots of opportunities. I think we have to prove that it works before we get the money sometimes.
Thanks for that.
Thanks. So Guy, I think Guy might also have a comment for you. He's also joined us now.
Thanks very much. And as always, I enjoy these Foresight meetings. And my compliments to both presenters. It was fantastic and very informative. To Dr. Mapham, part of my portfolio is engagement with the public sector. And at the risk of being blunt, the bureaucracy around getting patients into the empty spaces and empty theatres that we have, it's ridiculous. And it just takes far too long. And I think at some point in time, the patients disappears, and we would rather not get involved because of the time it takes to set something up. Having said that, I do know that, for example, in the Free State, we put a CSI project together with the public sector and in your space, the ophthalmology space, and we did 40 or 50 cataracts in a day over a weekend with a private doctor involved. Obviously, the costings and that all done and signed off by the department. So it can be done. And price, obviously, in the private sector, we don't do anything for nothing. So we're happy to do stuff at a much lower cost, and that was part of our process with the department beginning of the COVID pandemic. Again, frustration, getting contracts signed off, it just takes forever. I think in terms of our engagement as Mediclinic with the department and through HASA, the Western Cape was the only department of health that managed to get a signed off contract. By then it was 3 or 4 months into the pandemic. So we're willing, and the availability is there, and there are doctors who have a social conscience who are prepared to pitch in and help the department where available. Again, as I said, it's the bureaucracy, I think, is what's slowing it down. And I agree with you. We can sort these things out, but they're not agile, which is a frustration.
Yeah, I guess to your exact point, it depends at which level you talk to the departments of health. So, for example, if I had waited to get permission from the provincial Department of Health to build VULA, I would never have got anything built. No. So you can talk at certain levels and never get anything done. That's perfectly possible, and actually is a waste of time. I think if you look at politicians in the high levels of Department of Health, they've got so many different competing incentives and priorities that it's very hard to get something practically done sometimes. I would definitely support what we found is that the clinical heads of departments are the key role players in many of the hospitals. So for example, Dave Stead for infectious medicines in East London, or at Kimberley Hospital with the ophthalmic department there. You've actually got incredible people on the ground that will make any system work. So I think rather than going to kind of at the political level, go to completely practical level. So these are people that do have access to small research budgets and are very keen to make their systems better. These are the people that actually drove VULA because they knew that their systems had to improve. So I would definitely, we know a lot of these people now. We've got a nice network now of all these kind of key people who make things work. And so I think there's a huge opportunity to maximize our network, work with you, and make some practical things happen. And I think just starting small and building up would be very practical. I think that would be a nice way to work with you. And I think what we've done in a kind of reverse is once we had scale, then the politicians took us seriously and said, oh, this actually does work. There's evidence. You had 2 papers published. Okay, now let's have the tender. Rather than having a bash on a tender for something that may or may not work, which is not government's prerogative. They can't experiment necessarily. So I think it is tough for the politicians, but maybe we can make things easier for them by showing them things that work, showing them exactly how it works. And then I think it's easier to get the buy-in that perhaps you're looking for. But looking forward to working with you. I think that would be exciting.
We're always keen to try something new.
I think, again, thanks, Guy and Odwa, for being brave enough to come onto the stage. And let me just say to all of the attendees, Odwa's immaculate background and hair and shirt was not rehearsed. Maybe he knew something I didn't before we started this session. So just to be really clear, we were scheduled to only run until 10 o'clock, but some of the feedback we got from our previous sessions is that some of the attendees thought it might be useful just to stay maybe 15 or 20 minutes longer for more engagement. And if you have anything else to attend to, please feel free to leave. And if you have 1 or 2 more questions, perhaps we'll spend 5 or 10 minutes more, depending on ability. Guy actually did have another question for Sheetal on the low fatality rates in Africa. I'm sure you still want us to discuss that. And then Matthew Zylstra has left us since, but he does ask where, I'll just read it out loud, were any of your impressive models published during the progression of the pandemic? And I guess, I'm reading a little bit of surprise or perhaps even a tad frustration between the lines of Matt's question. But maybe we can deal with both of those questions, Sheetal, if you have a second.
Sure. So published, yes, our models and model code are available on the NICD website. So that's been around for a couple of months. So that I can answer Matt's question. With respect, well, if publish could mean two things. So one could be academic publishing or just putting it out on the internet. So yes, it's out on the internet. On the NICD website. But in terms of academic publishing, we haven't really had any time to write papers, and that's something for our December holidays, unfortunately. So we'll be good academics then, and publish our papers. We did have 1 or 2 sort of minor publications up, but not necessarily the key sort of South African model publications. The second question on the low fatality rates seen in Africa. That's a question that I think is many faceted. I think we'll take a couple of things into account. One is the lower age profile, the younger age profile in Africa compared to European countries, which would have resulted in less severity and hence low fatality. Two is we've got to look at reporting systems. The reporting systems are not well defined, certainly not as well defined as they are in South Africa, and we have reporting issues as well. So I think that reporting needs to be taken into account. Thirdly, we've got to look at preparedness. Africa has experienced the epidemic off the backs of learning lessons in terms of treatment and so forth from what has happened in Europe and America and so forth. So in terms of being better prepared, having one, the time to prepare, and two, better knowledge when it comes to preparing for the epidemic, I think that has helped as well. And then, of course, is there some unknown variable with respect to inherent protective immunity? No data for it yet. Could it be there? Perhaps it is, but there's no data. So I think we've still got lessons to learn and knowledge to be uncovered to understand properly why we're having such low fatality rates in Africa.
Thanks. Unless I'm mistaken, I think that actually does deal with all of the questions that were still out there. I'll give a second or a minute for someone who needs to urgently raise another question to just maybe post something in the chat or raise your hand. But in the absence of that, it remains for me to thank everyone for joining today. Thanks, Barry, for convincing two brilliant speakers to join us. And we really look forward to the next engagement.
It was easy. I promised cake. Although we shouldn't try and trim down on the cake now post lockdown, coming into the summer season. So maybe not cake, maybe a salad or something.
Yeah.
Cake. No, Sheetal wants cake still. William, you said a salad maybe. So yeah, I mean, we most of the folk have dropped off. We decided after our first session just to let the time run a little bit longer, because these things always feel like such an abrupt end, and it's like, okay, see you, and then you know. But just for those that are still on, a last thank you to both of you, the doctors, Sheetal and William. It's been, as I said, great to work with you guys and get to know you and learn from you both. What's possible, your incredible work ethics and your impressive skill sets and impact have been a great lesson to me. So thank you very much, and thank you for taking time out of your busy schedules to speak to us and some of our audience today. It's really much appreciated. Thank you very much.
Oh, thanks, everyone.
Thank you.
Thanks to the speakers.
Thanks, guys. Bye.
Thanks, everyone.